that's the economic burden that the payers are looking at, and therefore also the people who pay the payers, which are the employers or the government. But there's the big clinical burden, right? And so that's what we're relying on your expertise for today, is to help us understand, the clinical burden of lung function, the delays in diagnosis and what the downstream effects of that are, and the limited treatment options. So Dr. Danoff, could I ask you to kind of kick off that clinical burden discussion?
Yeah, and I think that this really goes back to a couple of the themes we've talked about before, which is, identification of patients who have interstitial lung disease, understanding what the etiology is. And once the etiology is identified, is there a therapeutic option that is likely to, benefit the individual? And then if the individual is treated with appropriate therapy, I mean, we certainly, we also worry about the use of medications and therapies that are not effective. We see lots of patients with ILD who are put on inhalers and various and sundry other medications, which really don't have any efficacy. And that really is a cost to the patient, because there's the cost of the medication, there's the cost of having to remember to take it, and the side effects of the medication. So really, ideally, what we want is to get to get as quickly as possible to what is the diagnosis, what is the best therapy available, and then to follow the patient to determine if that therapy is actually working. That is, if it's stabilizing, improving their lung disease. And if it's not, what are the alternative options? And, I think for a lot of patients, as Don pointed out, I mean, there are many kind of sentinel points. One of them is when people need to use oxygen, and all of a sudden their disease becomes very public because, people who might not have recognized that there was a problem now see them wearing oxygen. They know that there's a problem, those kind of things. But we certainly see plenty of employers who are uncomfortable with having their workers come back in wearing oxygen. So it can be a burden in their employment history. And then, as the disease progresses, people are less and less able to do the things that matter to them. And those things, depending on your phase of life, might be taking care of your children. I mean, this also affects people who are quite young. And so it can have a vast impact over a very wide age range. And ultimately, it can be life limiting. And so at that point, then we're also weighing in the costs of having to, consider lung transplant in our patients, which is a rare and very expensive treatment, and is unfortunately not available to everybody. So it has an enormous clinical burden, and has an enormous burden in terms of quality of life, length of life of our patients.
So Dr. Hummers, let me ask you, in your interaction, between trying to deal with the clinical burden while there are those around you, the payers particularly dealing with the economic burden, are they aware of what you're doing and what your patients are going through? Do you find that they're interested in outcomes and on productivity for their patient populations?
Well, I don't interact that often with a lot of payers, other than just trying to get our medications approved, I would say. But it is a challenge, and it's a particular challenge in rheumatology, where until nintedanib came along, there's not been one FDA-approved drug to treat systemic sclerosis, for example. And I think trying to convey that patients are sick, they're having progression, and we do have limited data for some of our medications, and there are reasons why we're choosing one drug over another drug depending on what manifestations of the disease they have. I think it's a challenge. I think it doesn't come across well, and like you said, in ICD-10 data and claims data. I write a lot of letters, right? We have no FDA-approved drugs for the most part. And so, but basically everything I give somebody is, again, until nintedanib came along for scleroderma patients, was off-label. And so I have to write a lot of letters explaining what that burden is, to say, hey, this person had to stop working, and they're having trouble doing their activities of daily living. And, so I think you need that level of detail, I think, to convey the whole picture.
And then I want to ask Ms. Rapola, you're going through this process as a patient. You're involved in seeing the clinicians, being monitored. How is that being conducted, and what's your experience like as a patient going through that level of monitoring?
So I have pulmonary function tests about every 3 months. And I have a 6-minute walk test, I think, that happens about every 6 months. And then once a year, I have a high-res CAT scan. And other than that, I just sort of monitor at home. I use my pulse oximeter, and I'm now at the point where I need oxygen when I exercise and when I sleep at night, and then during high stress times. So I have a portable oxygen concentrator. I sort of just monitor on my own. So that's what my monitoring looks like.